How apical periodontitis diagnosis ended the histologic terminology chaos in endodontics. Hello, I am Marwan Aburas. For years, the literature, textbooks, schools, and even major organizations have classified periapical radiolucencies in histologic terms. Some sources have referred to them as granulomas, while others have labeled them as cysts and abscesses. This lack of standardization has left clinicians confused about the diagnosis and, more importantly, the treatment. Imagine a periapical radiograph of a tooth with inadequate endodontic treatment displaying a 15 millimeters periapical radiolucency. And picture two clinicians examining the same radiograph. One described it as a cyst, while another call it a granuloma because of the size. But does this difference affect the patient treatment? Not really. We're going to do endo. The radiolucency results from poor quality treatment, and the recommended course of action is retreatment in this case. Endodontic research that has clarified this repeatedly, that the best evidence is radiographic evidence, is more clinically significant than histologic, which we don't see. In 1967, Brynolf cadaver study demonstrated that periapical radiographs are highly accurate in detecting pathology. Bender research in 1961-97 confirmed that a radiograph exhibits radiolucency when the jawbone is demineralized or cavitated. Orstavik showed with his periapical index that radiographs very good. And Estrela in 2003 used the same size of the lesion in CBCT classification. So all of these things indicate that the size of periapical radiolucency is significant. So why do textbooks, schools, examining boards, and dental organizations still rely on outdated histologic terms in endodontics? In operative dentistry, we diagnose caries using bite wing radiographs. In periodontics, we use bite wing radiographs and PA. In implant dentistry, we evaluate alveolar bone quality and quantity in using CBCT. Apical periodontitis should not be different. The best is the radiograph. To provide a clearer understanding of the first objective in this presentation is to demonstrate how the implementation of AB classification resolved controversies and the chaos that we had for years in terminology. Pioneering textbooks. I will share with you the sources where all came from, along, of course, with the different organization classifications. The third objective I have is to explain the necessity, the need for, and to share the evidence for a clinically relevant classification. This classification I have developed, and I have used it for the past 50 years in practice and education throughout my careers. And it's based on the lesion, or the radiolucency, or the apical radiolucency size, a classification in which I call initial, established, and advanced apical periodontitis. In a separate presentation, I have the details. For more information, please visit aburas.com, and thank you so much for your attention.